Nneka Hall, thank you so much for joining me today. I'm so excited to talk about just your work and the impact that it's had on me as a pelvic health therapist that's transitioned a lot into the hospital treating moms while they're still either on the high risk pregnancy unit or who have just given birth before they go home. And I really just want to talk about kind of our introduction. Uh, it was actually through Darlene Turner. She's who connected us, I want to say 2 years ago now, Nneka.
Yes, it's been about 2 years, and we've just been moving and grooving and just doing wonderful things since.
Right? I mean, we presented at Boston at the combined sections meeting for the APTA. And that really to me was kind of a turning point because I had never presented with you before. And even though we had talked about so many things, the impact is different when the audience, right, is a group of physical therapists and they're not used to necessarily collaborating with a doula in the hospital. And I want to start there because that's still novel. I mean, have you seen many instances where there has been a physical therapist collaborating with a doula while someone's in the hospital?
Not at all. And what I find is if there is a collaboration, it is because, and I've never seen it personally, but when it happens, it's because the person has the money to pay out of pocket for it to happen. So, this discussion is really needed because a lot of people don't even see the connection, the why of this.
Nneka, isn't that true though for just doula services? I mean, there's just not many. I mean, I know that there was um, 5 organizations back in 2022 that were approved for insurance reimbursement, 5 doula certifying organizations. But none of them, from what I understand, um, really, really to me, I think is fair to say is that they didn't include Black led organizations who receive that kind of like um, funding for insurance reimbursement for doula services. So, doula services, as it stands, that really have the ability to impact some of the most, vulnerable in our society, are not going to be covered by insurance. It's going to be an out of pocket expense. Is that right?
It is. It really is. And one thing that is, we now have Mass Health, which is our Medicaid program here in Massachusetts. Um, we've been able to they've approved doula services. So and they pay a decent amount, I would say, and it's also inclusive of bereavement support. So that getting that on there and having other states saying, "Wow, um, you mean you guys get paid to support bereaved families? Why not?"
That's where I was introduced to your work. I was searching for something more than just the bereavement services that were being given to families in the hospitals, because once they left, it wasn't guaranteed to continue. And so, can you explain a little bit more about that? If a doula is supporting a mom after she's lost her baby, she's getting reimbursed by Medicaid in Massachusetts, at least.
Yes. Well, it's not even reimbursing. What it is the doula that is supporting, who is trained in supporting families through pregnancy and infant loss, is nothing, at no point in time will that family be billed. Afterwards, a claim is filed by the doula who has already been pre approved, or who has been signed up as a mass health doula to support those families. So at no point in time will birth services be billed to the family if they are a Medicaid recipient. At no point in time will postpartum services be billed to the family, and definitely not bereavement services. And that's thanks to Christina Gable, who wrote the doula
Amazing.
bill here in Massachusetts. And when I found out years ago that she was writing this bill, I said, well, can we add in bereavement? And she said, of course, why not? And not only did she do that, she took out the gatekeeping portions, meaning that in most states it's white-led organizations. You have to train through them in order to become a Medicaid doula. Not here. And there are several tracks. There are traditional trainings that you could have taken to become a doula and certified through, but you don't have to be a certified doula here. You just need to pass the exam with the core competencies. Sorry about that.
Nneka, what do you mean? The core competencies. What exam in Massachusetts do doulas have to pass in order to be, um, I call it reimbursed, but either to be in network with Medicaid?
Well, what it is it's just showing that you know the basic skills of the doula.
What exam?
Well, it's not really, I haven't taken it because I'm a certified doula, but it's just something showing that you know anatomy and physiology, that you're not going to just say you're trained or you have experience in this, but you're also someone who is knowledgeable of it. So let's just say Joe Schmo on the right hand side decides that they see that this is as an opportunity. They're going to be asked questions that only people who are knowledgeable about the reproductive body will know how to answer. That's all that they're asking is for you to show that you have that knowledge. It's
Yeah,
not it's not the same
yeah.
exam that you would take were if you were to certify through a certifying body, is what I'm
I
trying to say.
understand. Okay. No, this is completely like you're blowing my mind because
It's a game
honestly,
changer.
it's a game changer, but you're saying this is exclusive to Massachusetts.
Yes.
As of when?
December.
December of 2023.
Yes.
Amazing. We have talked about this at length about physical therapists not yet really a standard component of care while people are in the hospital. They're not really a standard component of care when people go home. Again, we're very honestly, talking about this discussion. If someone is privileged enough to even know to have a physical therapist involved in their care during pregnancy, they're more likely than someone who's never had those services to follow up with that person early enough. But as it is right now, the standard of care for physical therapy involvement is until someone develops complications. We've talked a lot about that there are many people who are walking around with ticking time bombs,
Mhm,
right? Especially after
mhm.
birth, there's such a huge cardiovascular component that they don't know that they're at risk for complications. So how would you know unless you are practicing evidence-based practice?
Right.
Evidence-based practice is actually doing the evaluation. It's not waiting for that person to develop complications and develop issues like an infection from a C-section because they were trying to pull up on something to get out of bed. No one taught them how to log roll. The evidence-based practice that we're advocating for is for you to do the evaluation to determine if that person needs more help. And with moms who are single, who don't have that support, who don't have a second person or a huge community to lean on, who may have stairs that they need to negotiate if they have an unexpected C-section. Right now, Massachusetts are there in terms of the doulas who are in network with Medicaid, they're on the front line for this patient population. They
Yes.
could actually be given a doula if they have Medicaid insurance. But I want to have an open discussion with you about that. How well prepared is that doula um, to screen someone who may have a cardiovascular issue, who may have be at risk for preeclampsia, who may be at risk for heart failure? How well equipped will that doula be able to be involved in their care and alert the medical team?
That's not a part of our training.
It's not a part of your training.
That is not a part of that's beyond our scope. And we've talked as you said, we've talked about this. Why not add in, just as we have lactation support right after post during the postpartum phase before you go home from the hospital, and you see your OBGYN, and the baby sees the pediatrician, and anyone else that might need to be seen. Why not have the physical therapist right at bedside, within a certain amount of time, be it the day after they give birth, or the day that they give birth when they're moved from labor and delivery down to the postpartum care unit. Why not have that a part of that bundle, so that those of us who are not, I mean, I would know what preeclampsia looks like because I've had it.
Wow.
But I haven't had postpartum preeclampsia, but I would know what to look like because I've worked as a high risk doula for umpteen years. Um, but for a new doula just entering the workforce, or a doula who is not trained in high risk support, they would not know what to look for. And it's not enough to say to your client, I think you should go to see a provider, something's going on, and the client can decline, and that's another casualty.
The
So,
dynamic duo between us, to me, makes so much sense.
mhm,
I'm not waiting around
no.
for that client to say, yes, you're right. Let me call my provider. I'm contacting the provider. But as a doula, I think most people who are just not familiar with just doula services at all, that is beyond your scope. That would be putting
It
a
is.
lot on you to say, be aware of signs of acute heart failure after birth, be aware of signs of preeclampsia, or even an issue of sepsis, right? We know that in those cases, sometimes the heart rate could rise, but the blood pressure could be going down,
Mm-hmm.
right? We're always on the lookout for high blood pressure, but not many people are trained to be on the lookout for low blood pressure, which I learned honestly from working with Dr. Catherine Sylvester, because
Mm,
she does a lot of the remote monitoring. She's able to see vital signs in real time, even if that person is in the hospital and she's at her computer at home. And so when you talk about your network and your team, you mentioned lactation consultants. We know doulas are working and collaborating with midwives, but in
mhm.
terms of physical therapists, where do you see the benefit for a doula to be collaborating with a physical therapist?
It's 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 a necessity. When you look at the pregnant and the postpartum body, there are over 40 people that need to be in support of that body, 40 different disciplines that need to be in support of that body. And of course, physical therapy is one of those, or a physical therapist is one of those disciplines. Um, in order to make sure that that person remains healthy, it's not enough for them to survive the birth. They need to live in a way that they can look back on that pregnancy or postpartum period in a positive manner and not be traumatized. We have so many people who have been traumatized from X, Y, and Z experience that could have been, not even a factor had we brought in someone like you. We have people who have passed away that could have been here today had someone like you been available at their bedside right after they gave birth, or within a certain amount of time after they gave birth, to teach them the warning signs, to teach them how to get in and out of bed, to teach them how to get up and go to the bathroom on their own after a C-section or even after delivery. Because we do have issues of postpartum preeclampsia that happen to those who have not had C-sections.
Nneka, you're
So
so right.
why not arm everyone with the tools that are necessary to live longer, healthier, happier, less traumatic lives, or less traumatized lives?
Nneka, do you remember there was a case, it really had just happened. This was before we were in Boston together, and then we just gave our presentation. at CSM, and I told you about a woman after a vaginal delivery. She didn't have any complications during her vaginal delivery. And I interviewed you and I told you about her case before we went on stage. And she had a little bit of pain. And that's kind of what her main symptoms were. Her pain was in the front of her throat, and her pain was kind of sort of on her left side. But they thought, the left side of her neck, they thought it was because of how she was positioning herself to breastfeed her baby. Within 3 days of her vaginal delivery, again, not complicated, maybe had a spike in blood pressure, she was readmitted back to the hospital for acute heart failure and for postpartum preeclampsia. Her BNP, which I know doulas are not trained in knowing the lab values and things that we would look out for in the acute care setting as physical therapists, as nurses, as doctors, her BNP was in the 700s. Nothing should be that high. That was indicating heart failure. And so that, to me, when you say not everyone has a C-section who is in need of that help, of that surveillance, you're absolutely right. She had a vaginal delivery. And I'll tell you one thing, she would have never been seen by an occupational therapist or a physical therapist in the hospital because she was walking around fine. We as a profession historically wait until people develop complications. You as a profession are there to support them through a successful delivery, right? And recovery. A postpartum doula is there for the recovery. So you're inherently built to prevent or to reduce complications. We're inherently, if we are billing providers, if we're seeking reimbursement from an insurance company, we have to justify a reason to be in the room. And that's where I feel like a connection with you would be more beneficial if doulas had the breadth and depth of knowledge as you do, Nneka, working with a high-risk population. You can see things that a normally trained doula cannot see. I'm gonna say this, and you could disagree with me. I really want to know your thoughts. But do you think that doulas should be given more resources to look out for these complications because patients are just not they're not complicated. They're just not.
Absolutely, absolutely. We definitely need more than, oh, now there are one-day trainings. You know,
For
we need
doula, I'm
for
sorry, wait.
doulas.
For doulas, for someone to become a doula, there's a 1-day
There are
training.
now one-day trainings. I've heard people say, "Well, I took a 4-hour training and now I'm a doula." Um, I have to admit, when I first became a doula many, many years ago, um, I needed certifying births as that was one of the practices. Um, and when I came back home, because I trained in New York and came back home and to get my certifying births, and I reached out to the doula community, which was mainly white, and they gave me the births that they didn't want, which were all complicated births. They had no idea what they were doing. And to this day, I say thank you because that really taught me how to be. That really taught me that I needed to know more, that I needed to read more, that I needed to be in certain settings. I needed to reach out to people like you and be connected with people like you to learn more. And yes, this is something that we should be able to, we should know how to screen for um, mental health issues, PMADs. We need to be screened for these issues that we're discussing today and a host of other issues, especially since we're spending more time with the families than the average clinician will be able to. They can spend what, 15, 20 minutes in the hospital setting per client. We're spending hours. Our clients are calling us, with or texting us or emailing us or in constant contact with us on a regular basis. Why not teach us how, give us the tools to say, you know what, I really think we need to make a call. Better yet, let's just go in. We're now learning more about fetal monitoring. We're now learning more about counting kicks to teach our clients how to do that themselves to save, prevent stillbirth. Why not teach us this life saving tool? Not for the sake of diagnosing, but for the sake of saying, okay, we need to be able to say to our clients, um, you need to be seen, and you need to be seen right now because you're in, without worrying them, but knowing what an emergency really looks like. Because as you know, someone can be walking and talking and sadly be dying or
Mm.
on the verge of death, when all it would be for us would be to say, okay, this, that, and the other. I'm one of those people whose blood pressure tanks after birth.
Mm.
I already have an abnormally low blood pressure. So when my blood pressure went up to what appeared to be normal, that was high for me. And that's how it was missed, and I lost my daughter because of it.
Nneka, I'm
Now,
so sorry.
as a doula, knowing these things, knowing that our clients' blood pressures, they're resting a normal blood pressure is not what we would consider in the field a normal blood pressure, but their normal blood pressure might be low. So that means that when it rises to what the normal is, it's high for them. And understanding that everybody is different and to treat
Now,
them that
could we talk about this a little bit more deeply? Because I don't want this to be lost. This is really important. You you just shared something that I need to understand for myself. You run at a normally a lower blood pressure.
way.
Our current guidelines set alerts at 140/90 for the maternity population. So anyone during pregnancy and postpartum, 140/90 is an alert. We need to respond.
Hmm.
You're saying that you run at a low blood pressure so that when you actually got up to what was normal, that was high for you. You wouldn't
Yes.
have even gone to 140/90. And you
No.
said that's how you lost your daughter.
Yes, because instead of monitoring the blood pressure, they were monitoring, since my blood pressure wasn't high, and they just looked at as an proteinuria being an unclean catch for 2 trimesters, when in actuality my blood pressure rose to the normal level, what's considered the normal level, and I went from trace amounts of protein to proteinuria in my urine to 3+ at the day that I found out my daughter had passed. But yet it was not considered preeclampsia because my blood pressure was not as high as what high would be considered.
So because your blood pressure didn't fit into their protocols,
Mm-hmm.
they missed it.
Mm-hmm.
Here is why I think I advocate for collaboration between physical therapists and doulas more than anything. Is I believe after going through at least DONA, I know that that's not a Black-led organization, but that's the training that I went through. And I did learn a lot, but I learned most importantly is that you're not trained on protocols.
Mm-mm.
That's a blessing, Nneka. I think it's probably been a disservice to my practice the most that I've been trained on medical management. And I say it's a disservice knowing that I call myself a doctor. I've done umpteenth years of training and certifications and licenses to get to this point. But it's a disservice because that's seared into my brain to understand the
Mm-hmm.
medical model and to put people into protocols, try to fit them. It's like shoving a square into a round hole.
Yes.
Whereas when you don't even have that training, it's a blessing because you're just able to look at the person.
Mm-hmm.
You don't have to argue with the doctor. You can speak directly to your patient,
Mm-hmm.
to your client, excuse me.
Mm-hmm.
And if you are concerned enough, I think where we're kind of now drawing that line is, do you still go outside of your patient's wishes and speak to someone on their medical team? And I think that's kind
Right.
of the conversation I want to start having, because if you recognize that this person is at risk and could be walking around with heart failure, do you say nothing as a doula?
I say nothing to the medical team, but with my clients, when I was a practicing doula, they knew that if, and this was a conversation that we had, and I hope if there are doulas watching, this is a conversation that they have with their clients prior to getting to labor and delivery. Um, if I see that something is not right, I'm there to support you. I'm there to support your family. I'm there to support the baby. If I see that something is not right, I'm going to tell you. And what that means is that is time for you to act. Because I wouldn't be saying anything if everything was happy, happy, joy, joy, every, the flowers, the hearts, the balloons, etc. If you choose not to act upon it, I can't do anything. I cannot go to the doctor and say, "Don't you see this happening?" If I did, you'd think something was wrong with me because I'm not there for them. I'm not there to speak to them. And that's outside of my scope of practice.
So now I want to give you some scenarios. So I have had doulas in my community that refer clients to me.
Hmm.
That's a blessing
That
because I
is
can do what you can't or what's not
right.
in your scope. And so those doulas in that relationship that I find is most valuable is because I'm in the home within the first week, Nneka. I'm not waiting until six weeks to see someone. I'm in the home within the first week because that home looks a lot different than the hospital room.
Yes.
They're up and doing laundry.
Mm.
They're walking and carrying their baby. That's very taxing on a body that might have a lower hemoglobin, have lost considerable amounts of blood, and that could be taxing their kidneys and they don't know it. And so, me in the home taking vital signs, assessing their support system, screening their mental health, to me is a perfect partnership with you because you are bound by that client doula confidentiality, whereas I'm bound by the expectations of my license. If I'm
Yes.
seeing something, I have to say something. And so, to me, any doula in and out of that person's environment that close, so close to the time they've given birth or right before, should have some type of relationship with a medical provider, and it's usually a midwife. That's really a lot where we see such life-saving measures already happening in this world, but 98% of births are occurring in the hospital. So how do we even make that more robust?
So what we do is we make sure, I mean, I happily would refer to you, um, and others like you. We just have to build, I mean, you and I have spent time building the relationship so that I can trust to send my clients to you. However, the average support person has no idea that you're needed.
Mm.
Um, an experienced support person knows that you're needed, but a person who is taking a DONA training is not going to understand why you're needed. There are a lot of wonderful organizations that do teach this, teach the need, teach the supports, but it's rare. It's highly rare. So, yes, I would refer directly to you as I have to other providers in my area. Um, but the average, like I said before, the average person has no idea that you're needed.
I
So
think
the
honestly, yeah, Nneka, that goes for women's health, right? I
right,
mean,
right,
be honest,
right, right.
a lot of people, I'll tell you, I started out my career in oncology and cancer.
Oh wow.
I couldn't even tell you how many women would tell me and they have now this lymphedema that's irreversible. It's a chronic condition. And they were like, I never even knew I should have seen you after my initial surgery when they removed the lymph nodes. I didn't have any swelling then, but I could have benefited from this knowledge. That's women's health. Nneka, we are the last to know as women what to look out for in terms of our health care. After hysterectomy, they're ready to send you home. It's the same thing after C-section. That is women's health. That's the epitome. I did a residency at Duke University in women's health physical therapy. And Nneka, Who was I seeing 2 to 3 weeks after surgery? Men after prostatectomy in a women's health residency. I say
Of
that publicly
course.
because what's that?
Of course.
Of course, not after hysterectomy, not after C-section, not after even vaginal delivery where a woman could have torn a third, fourth degree tear. I was seeing men after prostatectomy,
Hmm.
right? I understand that this is an issue in women's health, and the direction you're taking with your career is exciting to me. It is something I want to build. Um, you're taking a whole woman wellness approach. You're branching out. You're getting into public health space. You're finishing your degree. Where are you going? And please take me with you. Let's
Well,
talk a little bit about this.
well, you're with me because we can no longer afford to wait for our client to decide that they want to start a family. We have to see them at younger and younger ages to normalize the practices that we expect them um, to utilize at an older age. Once they get to that point, there is no reason why we should just be hearing about infant mortality and maternal mortality after it's happened. It's been happening for so many years. Let's talk about certain things and preventative measures when they're 3 and 4 years old. Let's teach them how to eat. Let's teach them how to exercise. Let's teach them how to strengthen their cores. In the United States, we are the worst when it comes to women's health. And I'll say that because in other countries, it's tradition for children who are raised as females or identify as girls from an early age to learn how to support their back, to learn how to support their uterus. It's that's lost in translation here in the United States. Teaching our young women not to do heavy lifting because of what it can do to the pelvic floor or what it can do to the uterus.
Or teaching them how to lift heavy because they're
Yes,
going to do it, but do it properly. So
exactly.
you're now taking your career. You went from doula, from perinatal care, and you are now focusing on childhood education, menstrual health,
Yes,
reproductive health.
yes. And I'm still doing what I was doing. I'm still working in the perinatal loss field. But let's look at the root causes. Let's work from the root cause backwards and understanding that we as women are born with every egg we're going to have. And by the time we get here, it's already been conditioned for X, Y, and Z genetic issue. And it's going to take 3 generations out to fix the damage that has been done. So let's work on fixing that damage. So we won't be here for the 3rd generation, most likely, but get them on board, get them to the point where they can see that if I eat this, then my body will respond in this way. If I eat that, then my body will respond in that way. So therefore, I should be eating this more than that. Exercising, etc. Um, I'm not happy with the way that my body is right now. I'm not happy that at 50 I've had both hips replaced. I'm not happy with that. I'm not happy with hernias or other issues. There are so many people who reach out to me because they've had PCOS or endometriosis or what have you, all of these issues that you can address and identify at earlier ages so
Mhm.
that when they get to be in the reproductive health ages that we're not seeing the same things we saw when they were younger. Let's identify things that can be prevented and prevent them. There are so many secrets out here that are being kept by the individuals that the holders, and being disseminated to, it's being gatekeep kept, as what I'm trying to say.
Mhm.
Why not open those doors and let the floodgates out so that we can all live healthier, happier, less traumatic lives? Especially when we're trying to do the thing that should be the easiest thing in the world, and that's have children, or even just live comfortably and pain free.
I completely agree. You hit on so much there. I'm thinking, and I've spoken publicly about this case with the youngest woman, right? If I can even say that, that I saw after C-section was 13 years old, and her mother found out on the day of her surgery. And I think if we gave ourselves permission to start earlier in our communities with this information, talking about period and menstrual health to our younger women before they even start their menstrual cycles, making sure our young boys are just aware of their bodies and of relationships and of the impact um, on our mental health when we're younger, on our physical health. I don't think that mother would have had to find out her daughter was having a C-section in a few hours
Right.
that way. I don't think we have to continue that generational health issues. The
Mhm.
American Journal of Cardiology predicted by 2060 the Black population in the U.S. would have the most significant impact of burden from cardiovascular diseases,
Say it again.
right? By
Say it again.
2060,
2060.
the U.S. Black population will have the most significant burden from cardiovascular diseases, and I don't think that has to be our future. That's a prediction that's based on models from today. And me as a physical therapist, especially a pelvic health therapist, a women's health therapist trained and board certified by my governing bodies for physical therapy, I'm waiting for women to come in with issues that are so debilitating from PCOS, from endometriosis, from pregnancy and postpartum related complications. We're waiting for incontinence. We're waiting for constipation. We're waiting for pain for sex, right? And a lot of us on the front line that are not waiting, that are trying to catch people even during pregnancy, it still feels too late. How
Mhm.
many of us are in childhood education? How many of us are trying to prevent those 11 and 12 and 13-year-old pregnancies and complicated deliveries in a child that's actually still developing? I don't know that I ever even thought about that kind of shift. I think
Mm.
about preventative care all the time, but I don't think about the shift that you've made in your career to start teaching children, because we need to be several generations ahead
Mhm.
before 2060 comes around.
And one thing that I find interesting is the fact that there need to be more of these types of conversations where we're not afraid of telling the truth. 2060, we blink, 2060 will be here.
Oh, yeah. It's
But
right
one
around the corner.
demographic that you didn't mention are the elders who think it's a rite of passage to sneeze and pee, not realizing that no, you if you would just couple a little tune up with a pelvic floor therapist, then that doesn't have we could put poise and depends out of business. But thinking it's okay, because my mother did it, my grandmother did it, my great grandmother did it. I don't want to do it, especially now that my son told me that one of the number one calls that he gets is because someone was running to get to the bathroom.
Mm.
And then they ended up breaking something and hurting to the point, and they still ended up wetting themselves. So why not look at the whole person for every phase of life that they will be in, and work with them in that manner from the womb out. When I say from the womb out, as soon as the person finds out they're pregnant, what do? They start eating properly. They stop all of, well, most people stop all of those bad habits. Or if they've had issues conceiving or have had a poor outcome with a pregnancy, they may a year, 2 years. Me, I did 2 years before I started, before I conceived my rainbow. I gave up everything that was bad for me, including coffee. I only ate healthy and organic. And first tryout, I had, got pregnant with my rainbow baby. But let's take it a little bit further and look at doing this sooner, way before you even think about getting pregnant, way before pregnancy is possible, and then work forward. Like I said, from the womb out.
I love that. From the womb out. How early, I want to kind of bring this full circle, but how early do you intend to start working with clients? What
I would
populations,
love,
what age groups are you going to go after?
I'm thinking, I love 3-year-olds. So I'm thinking three.
3 years
Um,
old. Yeah.
but think about it this way, and we've had this conversation. What if we taught families, we had a certain, a test pool, so that we taught families how to eat properly. Um, and we started, and then they were able to replicate and replicate and replicate, and to see how that would work. Because that 2060 number, it might not affect me because I probably won't be here, may not be here, etc. But it will definitely affect my children. And the thought that they might not be here because of cardiovascular issues is really frightening to me.
Mhm. You know,
Um,
I'm trained and I treat pediatrics, with pelvic floor issues. And you're absolutely right. 3 years old is not uncommon, especially if that child has had at that point, lifelong constipation issues or issues with emptying their bowels. If they've been diagnosed with something called a megacolon, it has not been uncommon for me to be working with both parents in the room, and there might be an older child that doesn't have those issues, and that young patient, and be talking about nutrition for the whole family. I've done that.
mhm,
But you are now saying, let's do this as a standard, not waiting for the one child to have those issues, but actually introducing nutrition, which we do a lot with pelvic health therapy. But you, with your doula background, with your training, with your bereavement support, you're like, let's span out. Let's
mhm,
actually teach and train the whole family when they have children under the age of 5.
mhm. Because think about it, at 3, their vocabulary is formed. They have a better understanding of grasping certain things. And if they understand, especially if you put it with a song, or a little bit of music to it, to teach them how that, certain greens will be appropriate for them and what they do for their body, make it really catchy and fun. Um, they'll be annoying, and they only will want those things. They won't want the McDonald's. Oops, I shouldn't have said that, should I have? But they wouldn't want the fast food. They wouldn't
That's true.
want, the things that are now doing damage to the bodies.
That's
Teach
true.
them how to
Yeah.
make those things that all kids love to eat at
Mhm.
home. Those prepared meals that you can prepare, mom, dad, grandma, big sis, big brother can prepare at home, so that
Right.
they're a lot healthier options, and they know where the food is coming from, and they know the quality of the food. So I think reaching them earlier, and we'll also see different outcomes for when the girls get their menses.
Absolutely.
And also teaching people earlier when their menses is not, how can I say it in a nice way? When their menses is painful at an onset of period,
Mhm.
teaching them how to manage that. My my herbal mentor, Martina Black, taught me at an early age how to handle my daughter's menses, my oldest daughter, when she got it, because it was horrible from day one. And just by adding in a supplement, an herbal supplement, that changed the way that she will. 'Cause I never wanted to hear her say, I hate it. Oh, I regret having it. Oh, I don't want it, etc. I never wanted to hear those words come from her mouth. Never wanted her to be in constant pain or dreading her next cycle. And she doesn't,
How
because
how old is your daughter now?
she's 18 and she got her first at 10. She had just turned 10 like a month earlier.
Nneka, I told you my story. My menstrual cycle started at 11. From day one, I think every month up until at least 16, because that's when my mother started to change things, and I'll tell you why. But from 11 to 16 years old, every month I missed a day of school at least.
Mhm.
Or I would be in the nurse's office crying in pain on my side. My menstrual cycle was so traumatic. I hated. I mean, I was a cutter. I was very
Mm,
suicidal as an
mm,
adolescent and a teenager, and I hated my menstrual cycle every month. And it wasn't until finally at 16, because I could make my own decisions, but my mother went with me, I remember. And my primary care physician said, we have to do birth control. And that clicked with my mother and said, oh no. And that's when we started the herbal supplement journey. She found barley green and a whole bunch of other stuff I can't tell you I took. But I started to have non painful periods. But it
mhm.
took until I was 16 years old. And so, had I found someone like your herbalist or my mother that earlier on, I mean, that was awful, an awful time of my life. And I've been able to control it a lot more now. I mean, I know a lot more now, but I still have a little bit of dread when it comes. And I find that I'm okay. But just to have someone to talk to about that, I don't think my
Mhm.
mother even had pelvic health therapy on the radar. But I just think that for me, when I created Pelvic Health Network, was truly to find a network of individuals that could provide that wraparound support that a woman needs out of the womb, like you said, from
Mhm.
womb to tomb, because so much happens with our reproductive health that really does impact the rest of our lives. And you are in my network. You will be
Def
forever in my network.
Likewise. And what's funny is, and if anyone out here listening is having issues, definitely go to boogiedownbotanicals.com and order some motherwort tincture. She now has one with hawthorn berry in it, and that one is for older folks who have been going through it for a while, because that hawthorn will help soothe that mood. But
Say it again, Nneka.
motherwort tincture
Yeah, but what
from,
say the
oh,
site?
boogiedownbotanicals.com.
Boogie Down Botanicals. Now that's what's up.
Yes,
Let
yes, and everything is harvested by Martina from her own. She has this forest, I call it herb forest, out behind her home, and when she does her nature walks and she videos tapes them, I'm like, oh my god, I would love to do that. And then a bug will go flying by, I'm like, never mind. But motherwort tincture has changed our lives.
I'm
It
looking her up right now because I mean, a big part of what my issue was, gosh, now, Nneka, it's since 2017 I've become a vegan. I've gone
mm,
plant-based, fully plant-based, just because.
I
Um,
couldn't last 6 months.
I know, I didn't think I could either. No, I mean, honestly, it was because of the threat of hysterectomy, and I went through
Mm,
3 OBGYNs. The 4th one was a plant-based, doctor of osteopathic medicine. She was like, "Just try it.
they're the
Let's just
best.
try this. Why not? Let's just try it." And she was a DO
Yes, that's what I
OBGYN.
have.
Never had that before.
Mm,
DOs are just on a
yes,
different level.
yes,
They are on a different level, but I'm looking at this Boogie Down Botanicals because I
yes.
still feel like, yes, I'm vegan, but there's so much more I don't know about nutrition, so much more I just don't know about just the impact of like, you could be doing something for your reproductive health during your childbearing years that you have to pivot for
Yeah.
your post, your menopausal years. And it's just, our bodies are constantly changing. And to be so ignorant of that, even as a pelvic health therapist, there's just so much that I want to connect with and want to know more about.
Well, that
You know,
motherwort tincture is life, and
I'm looking right
once
at
you
it. This is
start
amazing.
taking it, don't stop, because your symptoms, as soon as it's out of your system, your symptoms return. And I didn't know my daughter had stopped taking it, and I didn't know what was wrong with her. And we ended up in the ER, and we're sitting in the second ER, different day. And I said to her, I don't understand what's going on with you. And then something said, ask her. And I said, are you taking your motherwort tincture? She said, oh no, I've been here healed. So I stopped taking that a while ago. And I said, okay, that was what the difference was. She was having a PMS issue. And see, one thing that we're not well versed in is what PMS is, what PMDD is, and what the symptoms are. And understanding that from the onset of your cycle, this stuff can change your life and can change the way that you view your cycle.
Nneka,
And
explain that. PMS versus PMD.
you're asking me to explain something that I'm still. I think I had PMDD is something that alters your mind, so it can affect your mental health. Yes, PMS can affect your mental health for a different reason, but that's shorter. PMDD is something, premenstrual
Dysphoric
dysphoria
disorder.
disorder. Yes,
Disorder.
it's something that still to this day remains undiagnosed in people. Um, Everyone wants to throw everyone else into the same little field, into the same little pocket or side. When we have to understand that some people, like I believe I had PMDD as a child in my youth, because I was always seeing therapists. My periods were horrible. The mental health side leading up to my period was absolutely impossible. Like you, I was suicidal. I was diagnosed. I
I
got my
I
first
I
period at
promise you,
9.
I've never heard of this.
Well,
As
see,
a
this
pelvic
is,
health therapist, I have never heard of PMDD.
well, understand that it's a lot different than PMS. And we're all told it's just PMS. Oh,
I've
you can
always been
manage.
told I had horrible
Well, nope.
PMS.
And see, if you have the right gynecologist, you'll be correctly diagnosed and put on the therapies that are needed. But with motherwort tincture, and I'm not saying that it works wholly for everyone, but I can tell you from day one, the very first day my daughter got her period, it was horrible. But after she started taking motherwort tincture and using herbal based pads, versus the things that we can buy in the supermarket, um, I noticed a change. I wanted for my daughters different than what I had. I didn't want them to be called crazy because, something with their cycles, the chemical side of their cycles interfered with the people that they were. I wanted more, so I learned a little bit more. And I shared everything that I've learned in everything that I've done. And now I think using the public health piece and digging deeper into the root cause of everything that we're seeing, that's when we'll be able to see a change. And understanding that doulas are not gods. We, in addition to you, Rebecca, and to every other discipline that's needed to hold up the people that we support, will allow us to change, to shift the paradigm in Black and Brown maternal health.
Nneka, where do you see yourself um, really really taking, I guess, almost the doula profession? Um, if I understand that there's kind of a that's a fine line right now, because we're talking about so much that you're not necessarily in doula work, but you are highly instrumental and highly uh, influential in where that field is going. Where do you see yourself bridging doula support as we know it traditionally, and then more of this public health work that you'll be doing for the rest of your career? How are you going to bridge that gap?
Well, I'll continue to teach for one.
So you are
I
teaching
I I
doulas.
I
You're
teach I train
teaching.
advocates. They're
You're
already
training
doulas when they
advocates.
come to me, but I take them to the next level,
So
I would
these are
say.
perfect. These are already practicing doulas,
Doulas,
but you're training
nurses, I've
them.
taught OBGYNs,
Understood.
um, and I teach them how to look at things differently. I give it to them in the raw nature that their clients will be seeing it. Um, with my public health hat, because doula turned maternal health advocate, turning public
Women's
health
health.
advocate,
Yeah.
focusing on women's health. Um, I see working from, as I said, from the womb to the tomb in a different manner, because and I say we because every step that I take, you're going to be there with me.
Mhm.
Um, but I honestly see, once we carve out the root cause of all of the issues that we see and we attack each leg by the root, I honestly say that with that, then and only then will we see a change in the Black maternal health crisis. Doulas are not the end all beat all. We are not the saviors. Yes, we are there to support our clients and to teach our clients how to use the voices that they already have. Yes, we should be knowledgeable of all of the people that should be touching, not touch, because not everyone's brought in, should be touching our clients, should be holding up our clients right alongside us. Um, Once we have all of those pieces working as one cog, then and only then will we truly see a change.
I'll end with this, and this is just kind of an aside. When you say that doulas are not gods and doulas are not the saviors, I almost wonder if that's coming from a larger expectation that's been placed on doulas when you say that.
It is. I mean, I see so much out here in the doula world, and I'm not saying we haven't pushed the needle. Yes, we are one support of many supports that should be brought into the space. Um,
But do you feel like there's been almost like a guilt placed on doulas that,
there's an
why didn't you?
expectation, this heavy, heavy expectation, and that's why there's such burnout
So
in
there
this
is such
field.
a heavy expectation on doulas, but yet that's not your scope.
Right.
Whereas in my profession, I've heard this more than once. Nobody has ever died who didn't get physical therapy. I hear that a
Wow.
lot. And when I think about that, Nick, I'm like, I keep hearing you say, we're not gods, we're not saviors. And then I see professionals who could actually take someone's blood pressure, who could actually call the medical professional, say, no one's died who's never gotten me, so I don't really need to show
Wow.
up. I'm telling you, it's
Wow.
like there's more expectations on someone who is not a licensed health professional than there is on somebody who is. Like, that doesn't even make any sense.
No, it doesn't. And we'll
Like,
do this
there are
again.
plenty of people who I can honestly say, had I not been there to provide a life-saving intervention, they may not be here,
Mm,
right? Unless I would have been in that room and been in that situation to screen and catch. So to me, the partnership between a doula and a therapist, especially someone who's practicing in women's health, it's a no-brainer. It needs to
definitely.
happen.
Yes.
Absolutely. But where you're going, I want to be. I want to
And
go where
you're
you're
gonna be
going.
there.
Nneka, to me, this childhood public health education piece, I feel like I am just lapping up water from a flood the more that I'm practicing reactive based medicine. If we're
Mm,
not working with children and doing kind of the 4 pillars that we talked about, to be honest with you, Nneka, we talked about mental health
mm.
big time. You've introduced me to a term, PMDD, that I didn't even know I had. right? We still don't know a lot of what was going on mentally with me as to why I was having those thoughts, right around the time I had my menstrual cycle and the
It's
therapy
all
that
a
I
part of
needed,
it. It's all a
all of
part of
it.
it.
So
And that's the
mental health
same
we
with
talked about.
me.
We talked about nutrition, herbal medicine, nutrition, and just kind of just getting to the root cause. But then we also just talked about the collaboration that needs to happen in our field as a whole. And so I see on your team there being a registered dietitian, there being a mental
Definitely.
health specialist, there
Mhm,
being a doula and birth support provider who's teaching children about their reproductive health.
mhm.
And then there being a physical therapist or even someone from allied health, from nursing, just talking about medical conditions and things like that so we can get that terminology into our communities a lot sooner. We shouldn't be sending people home who have no idea what we said.
That part.
Nneka, where can people find you and how can I keep you in my life forever? This is the part
You're
where we
already here. You're already here. You can find me at nnekajhall@gmail.com. You can find me on any platform using my name or at Mother is Supreme. Um, you can find me at Quietly United and Lost Together. You can Google me and find me all over the place. But I appreciate you and know that you're always going to be here. Your family now. We've known each other for quite a while, and I'm not letting you go because I have to have somebody do all of this with me.
I'll be right there. Nneka, it was a
Definitely.
pleasure.
Likewise, always is.